The following webinar was recorded as part of the original implementation of IWISH and has been made available for informational purposes only. Some portions of the original recording have been cut to ensure participants' privacy. References to the Lewin Group, implementation team, site liaisons, PHL, Google Drive, and some forms are not applicable to the demonstration extension effective October 1st, 2020. Terms and conditions of grantee's cooperative agreement supersede any information presented here. Please see the IWISH Operations Manual for the most up-to-date implementation information.
Alrighty, well it is 2:00 p.m. here on the East Coast, so we're going to go ahead and get started. Thank you to everyone who's joining us today for our webinar entitled Working with Trauma. Now, before we jump into our objectives in the presentation, I wanted to help frame our conversation a little bit and give you a little bit of background and insight as to why we're talking about trauma. Over the past couple of months, many of you have shared with us, your site liaisons, that while you are conducting the PCI and or the assessment, your residents have opened up about traumatic experiences. And the traumatic experiences have a wide range. The purpose of our webinar today is to provide you with some tools and resources and ultimately support that can help you in responding to your resident stories. We want to be able to show you how you can respond when you hear the traumatic experience, and then also help you understand what a trauma-informed approach means for your IWISH work. Now, don't worry, we're not expecting you to be counselors. We're not expecting you to be counselors to your residents, but we do want to help you in listening and responding to what they may say, and then also show you how you can support them in getting connected to resources that they may need to cope, heal, and ultimately live a healthy life while aging in place. So our objectives for today are to discuss what trauma is and how it affects the mind, body, and behavior, to learn principles of trauma-informed care and tips for engaging with participants who have experienced trauma, and then also to understand vicarious trauma and the importance of self-care. So without further ado.
Okay, thank you. And thank you everybody for joining today and for inviting me to talk. So today we're going to talk about trauma and how to work with clients who've experienced trauma, and also how to care for ourselves after we've been exposed to that trauma. So let's start by trying to define trauma with a brief overview. So first of all, trauma exposure is extremely prevalent. Over 60% of adults in the U.S. have experienced some kind of adverse event in their lifetime. And as we'll discuss later, those discrete adverse events only capture some of what trauma is all about. So 60% doesn't even reflect everyone who's been exposed to trauma in some way. The second point, trauma informs how we see ourselves and what we expect from the world. So if we are exposed to a traumatic event after our brains are largely developed, then it means that trauma not only informs who we are and what we expect from the world, but it fundamentally changes those things. If trauma fundamentally changes who we are and how we interact with the world, that means it can inform pretty much every interaction we have, including the interactions a client might have with you. And so we'll explore this more deeply later on. The third point, trauma overwhelms our ability to cope. This is a really important point because it helps distinguish between what might be maybe a stressful event versus a traumatic event. A stressful event puts strains on our internal and external resources, but we still manage to cope, and we walk away pretty much unscathed. Trauma, on the other hand, it overpowers all of those resources that we have to cope, and it forces us into a fight, flight, or freeze response. And again, we'll have more on that later. The fourth point, the mind-body connection, is really important in helping us understand how trauma works. Because trauma overwhelms our normal brain function, traumatic memories are at least in part imprinted on a part of the brain that regulates physical function and sensation. So when trauma is remembered, it often manifests as physical rather than emotional, and we'll talk more about what some of those physical symptoms might look like. Next slide. Okay, so let's dive deeper into our definition of trauma. As I'd mentioned, trauma is anything that overwhelms our resources and limits our ability to cope. specifically if we are exposed to an adverse event and we don't have the chance to escape or find safety, the more advanced centers of our brain shut down and more like primitive parts of our brains take over. And that means that we are fundamentally unable to integrate a traumatic experience into our narrative memory, and we're often left with fragments of memories. This also means that traumatic memories live with us in a way that is largely kind of unresolved. Next slide. So I've been talking a little bit about different parts of the brain and how they're affected by trauma. Here's a visual representation of what is called the triune brain theory. It's a kind of oversimplification of the different functions of the brain. So starting from the top and working down, these three sections of the brain are roughly presented in the reverse order in which they evolved over time and how they develop in each individual person from birth. So basically what I mean is that the survival state develops first, the emotional state next, and then later the executive state. So let's start at the top. First, in green, we have the frontal lobes. This is where our most advanced cognitive processes take place. This is the part of the brain that we use to plan or to problem solve or communicate. It's what they call executive function. The second part of the brain in blue is what we call the limbic system, and this is the part of our brain that houses our emotional state. And this is where feelings are processed. The communication between the frontal lobes and the limbic system is how we ultimately make sense of our feelings, or in reverse, how our thoughts might inform how we feel. Okay, and last in red, we have the brainstem. This is the most primitive part of the brain. It regulates our automatic body functions, the ones that we don't normally have to think about, like breathing, our heart rate, our digestion. And this is the part of our brain that, that we share with most other mammals. Okay, next slide. Okay, so now let's look at how these three sections of the brain react to trauma. And this is a quote from Bessel van der Kolk out of Boston University, who's one of the more famous trauma researchers in recent history. And he released a book a few years ago whose title I will name at the end of the presentation. It's called The Body Remembers. And it's one of the few books he's written for non-clinicians. It's a very accessible and interesting book, so I highly recommend it. But let's take a look at the diagram here. The process described here is what happens both when someone is actually experiencing a traumatic event and when somebody is remembering a traumatic event. They're very similar processes. So starting with the frontal lobes, this part of the brain actually shuts down in large part. Not entirely, but in large part. The video camera that is normally recording everything that happens to us, it becomes fuzzy or it shuts off altogether. And our ability to problem solve or communicate might be limited. And there's an evolutionary function to this. There's a reason that our brains develop this way. The brain is trying to transition its focus to the parts of the brain that are best equipped to deal with survival-related emergencies. Okay, so now we move on to the limbic system. And as I said before, this is the brain's emotional memory center. The limbic system is kind of like the fire alarm of the brain. It reacts to trauma or to remembering trauma on an emotional level. And as it says here, when remembering trauma, we may actually feel the same feelings we had when the original trauma took place. And because our frontal lobes are shut down, we don't necessarily have the wherewithal to recognize that the present moment is different and what we are currently, and that we're not currently in danger. So next we have the brainstem. They also call it the reptilian brain in the triune brain theory. And this is the part of our brain that I described as the most primitive part. It's ultimately what shares control with the limbic system when we are exposed to trauma or when we're remembering a traumatic event. The brainstem reacts to the limbic system's alarm and produces physical responses. Those reactions might include an increased heart rate, hyperventilating, muscle tension, upset stomach. This is also the part of the brain that controls the fight, flight, or freeze response. I'm sure a lot of you have at least heard of the fight or flight response. Freeze was added a little bit later. These are the instinctive reactions that we and other animals have when we're in danger. So different situations might trigger different reactions in different people, maybe more prone to one over the other. Let's take a second to maybe illustrate what that might look like. So imagine we're in the woods being chased by a bear. Your executive functioning shuts down, and your limbic system takes over. You experience a sense of fear and dread, and those feelings then signal to your brainstem that you are in serious danger. The brainstem then pretty much takes the steering wheel and engages in emergency maneuvers by signaling to your body that you need to either A, run for your life, B, fight the bear, or in cases where neither fight or flight is possible, then your third option is C, which is to freeze. This third option is in many ways the most frightening, because you might think that playing dead would be a wise strategy in some situations, but the reaction is actually your brainstem telling you to kind of give up and surrender because you've been thwarted. So, as I said at the beginning of the slide, this process applies to both the experience of trauma and the remembering of trauma. Because our executive functioning shuts down during a traumatic event, its memory is encoded in the more primitive parts of our brain, the limbic system and the brainstem. It's not encoded in the part of our brain that has access to visual or narrative memory, at least not in its entirety. There might be fragments encoded there, but not as comprehensively as other non-traumatic memories. And so this means that we remember trauma with our feelings and with our bodies, not necessarily with our thoughts. So we might experience feelings and physical sensations connected with our trauma and not even realize why. And that's why at the bottom here I noted that traumatic memories are not so much remembered as they are relived or re-experienced. I'm oversimplifying a little bit here to make my point. Clearly there are many people who are able to tell stories about the trauma, but this is often after a significant amount of time and effort trying to reintegrate those experiences. Okay, next slide. So we often think about trauma in terms of discrete traumatic events. And what I mean by that is we often think of things like natural disasters, exposure to combat on the battlefield, sexual assault, like discrete events that have a clear beginning and clear end. And these are the kinds of events that we often associate with the diagnosis of PTSD, post-traumatic stress disorder. But there's increasing recognition of something called complex trauma. And complex trauma refers to the result of multiple traumatic experiences over time. And this trauma is often developmental in nature. It might include things like sustained abuse as a child, abandonment or neglect by a caregiver, or uneven power dynamics in any kind of interpersonal relationship. Complex trauma can also be systemic or institutional in nature, and by that I mean that complex trauma doesn't have to be perpetuated by an individual, but it can be the outcome of discrimination or mistreatment by groups or an institution. So if you're a minority who has been repeatedly failed by systems meant to protect them, like education or social services, that result can be similar to some of the more traditional forms of trauma exposure. And over to the right, I specifically listed captivity as an example of an event that could result in complex trauma. We should think about captivity in a pretty broad sense, not just that an individual is being held against their will, but also as an individual being effectively held captive in like a marginalized neighborhood. So if you are systemically denied opportunities for economic advancement, you might effectively be a captive in your own community because you lack the opportunity to escape. This relates back to my point here, which is that complex trauma alters our experience of time. If you're held captive, you stop being future-oriented. It becomes kind of pointless to think past the present moment or the near future because your future is out of your control. So what I'm trying to say is that certain kinds of trauma make people present-minded, not future-oriented. And this has all kinds of implications for service providers like you. It might mean that certain people have difficulty showing up to appointments on time, for example, because they're sort of accustomed to not planning ahead, or our understanding of how globally trauma can impact someone's daily function will hopefully increase our compassion and patience, but it might also help us understand how to approach someone, which we'll talk about more shortly, And the entire point of this concept is for us to broaden our understanding of trauma beyond what we typically think of. Okay, next slide. Okay, so these are three terms that all get at the same concept. It's related to complex trauma in that it involves exposure to traumatic events over time. This type of trauma specifically refers to the impact of discrimination over time. And that discrimination doesn't have to be overt. It can be very subtle. The point is that exposure to these microaggressions over a period of time can result in symptoms of trauma exposure. Okay, next slide. Okay, so now we're going to facilitate a chat session.
Hi, Joy. Are you here with us?
Yes, it's the mute. I apologize. So now we want to hear from you. As I said, this is an engaging session. So we want to know, how has trauma affected your participants' daily lives? Now, we're not looking for specific stories exactly, but we just want to know, based on the interactions that you've had and the conversations, how have you seen trauma affect your participants' daily lives? Does it alter some of their relationships that you've noticed? Have you observed certain things that are different or that they may do differently because of the trauma they've experienced? So I see some answers in chat. Withdrawn, anger, avoidance, inability to form trusting relationships, mistrust, isolation, anxiety. Good responses. Feel free to type into chat anything that you've observed from your residents and listening that may be a result of trauma they've experienced. Avoiding big crowds, in big crowds, increased alcohol and drug use, depression and substance abuse. I have one that says, I have a resident who's very angry with her daughter and negative towards other people due to her traumatic past. Strong emotional reaction to being touched. Wants to engage with staff but not necessarily with peers. Withdrawal from community events. Great responses. Matthew, do you have any comments you want to make in response to the participants' chat?
Yeah, those are all really great responses and really common trauma reactions, especially a lot of you mentioned being withdrawn or having difficulty establishing trusting relationships. That is very true, and also something that certainly informs your work. Just even going in knowing that that person may have difficulty in trusting somebody who, they may be older than you, but in some ways you might be perceived as an authority figure. Somebody else had mentioned a reluctance to being touched. That's another really big one to be aware of, right? So that your normal impulse, which might be to put your hand on someone's shoulder, might be interpreted as sort of a dangerous gesture if it's somebody who's experienced a particular kind of trauma.
Thank you, Matt. I'll turn it back over to you to continue your presentation. Please feel free to continue entering your thoughts and your reactions into the chat. These are some really, really great responses that you all are sharing.
All right. I also apologize. I'm a little sick, so if I have to mute myself for a second to have a coughing fit, I apologize. Okay. Let's start to talk about, now that we've defined trauma, let's start to talk about how that knowledge might inform how we actually engage with clients. So we're going to start though at the organizational level. The phrase trauma-informed care has been getting more and more attention, and it refers to care that keeps the impact of trauma at the forefront at all times. So what does a trauma-informed organization look like? A trauma-informed organization realizes the widespread impact of trauma and understands potential paths for recovery. It recognizes the signs and symptoms of trauma in clients, families, and staff, and others involved in the system. It responds by fully integrating knowledge about trauma into policies, procedures, practices, and it seeks to actively resist re-traumatization. Okay, so this comes from the recommendations that came from SAMHSA. Yeah. Right, next slide. Okay, so let's move to talking about how your work as a provider can be trauma-informed. We'll start with the general principle of trauma-informed care. First, we have client safety. This is listed first for a reason. A client's sense of safety and emotional well-being should be the primary guiding principle in our work. Trustworthiness and transparency. This is an element of client safety. In order for our clients to feel safe, they have to know that, that they can trust us. And when I talk about trust, I'm being really specific. I mean that our clients need to trust that we have their best interests in mind and that we are going to do what we say we're going to do and not work behind their backs. Third, we have peer support. Connecting people who have had similar experiences is a very helpful way to work through trauma, and that often takes the form of support groups, other peer-led initiatives. And then fourth, we have collaboration and mutuality. For our clients to feel safe, they have to feel like we are working with them, not that they are working for us. The goals in the wellness plan should be identified collaboratively, not imposed on them, right? And so that leads directly to our fifth principle of empowerment. Empowerment, voice, and choice. Clients need to feel like they are part of the work and that their voices are heard and respected and that they have choices. And this is definitely true with all clients, but it's especially critical when working with those who've been exposed to any kind of trauma. And last, we have cultural, historical, and gender issues. This principle is pretty much meant to highlight that different identities will intersect with trauma in different ways. Sexual assault, for example, may take on a different meaning depending on a person's gender, age, or culture. Throughout all of your work, it's important to remember that people are extremely resilient. First of all, exposure to trauma affects everyone differently. So we can't make too many assumptions about someone's experience just because we know that they've had a trauma history. Second, by the time you encounter your clients, they've likely found all kinds of ways of adapting and living with those painful memories from their past. And some of those, strategies, somebody brought up substance use. Some of those strategies might not be the most effective, but people have found ways to get on with their lives, even before we stepped into interviewing with them. And the reason this is important to remember is because reminding a client of their resiliency is a great way to respond when they disclose the trauma history, and we'll expand on that a little bit later. All right, next slide. Okay, so now we're going to expand on some of those general principles of trauma-informed care and get more specific about how that plays out in practice. So like I said before, facilitating safety is key. One way to do that is to ask permission in order to ensure that the client feels empowered and in control. And this can range from asking permission to enter their apartment to asking permission to ask them some difficult questions. Okay. Work from a strengths-based approach that emphasizes current resources. This gets back to my earlier point about resiliency. When clients are describing adverse experiences, one of the best things you can do is remind the person of their strengths and how strong they must have been to overcome what they experienced. And when I say emphasize current resources, what I mean is that it's sometimes good to reflect back to clients the internal and external resources they already have. That might be a sense of humor, a good friend, or a supportive family. Okay, and then we get back to the idea of peer support, which I mentioned before. Peer support can be a really important way to overcome the effects of a trauma history. Being around others who understand your experience can be really powerful. Even if we as providers do share some of our clients' experiences, we can never fill that need because we're not their peers, we're their service providers. So connecting people to relevant support groups can be really helpful. Okay, next slide. Okay. Be attuned to any shame response. And I think I saw at least one or two people say guilt or shame when they were typing in earlier. To be attuned to any shame response. What that means is sometimes after people disclose traumatic stories to us, they might later feel ashamed or really exposed. And that can sometimes mean that they're less engaged in services or that they might shut us out altogether. So be aware of any behaviors that might indicate a shame response and work with your team to address that. Boundaries and limits are really important. You are likely a pretty important person in this person's life, which is why they're disclosing their trauma history to you. But that doesn't make you their therapist or even their friend. It's okay to set limits around your work if you feel like someone is sharing too much or relying on you too much. If, for example, someone's describing their experience in kind of gory detail, it's okay for you to stop the client and encourage them to connect with a mental health provider. If you find that someone is being sort of overly familiar or is asking you if you've had similar experiences, it's also okay to let them know that in general, you don't share that kind of information with clients. Okay, then we get to cultural competence. This is just reiterating the point that I made before about different types of trauma affecting different groups in different ways. Additionally, different kinds of trauma might be more common among certain groups. For example, institutional trauma related to immigration and customs enforcement is going to be more prevalent among first-generation immigrants, just for an example. All right, so let's move on to the next slide. Okay, listening to a trauma narrative. So we're going to talk about what it's actually like to be in the room with somebody who's disclosing a traumatic event to you. When someone does disclose details about a traumatic experience, it can be difficult to know what to say or do. And so for that reason, I put together a couple of tips. First, give them time and space and patience. And don't take it personally if at times they are irritable or bad-tempered or they want to be alone. These are pretty natural parts of the stress response. Don't try to talk them out of their reactions or minimize the event or say things like, you're lucky it wasn't worse, or pull yourself together, or, or try to get them to look on the bright side in any way. They'll feel supported if you let them know that you're concerned and want to help and that you're trying to understand. So first validate, then offer to connect them to help. You can do that in whatever way feels most comfortable to you. The script here isn't meant to be memorized or prescribed. It's just one example of something you might say, right? So what I've written down here is what you've just described sounds overwhelming. Have you ever thought about talking to a counselor about this? A lot of my clients who have been through something like this have found counseling to be really helpful. All right, next slide. Okay. One of the most challenging parts of listening to a trauma narrative can be figuring out how to end the conversation. How do you leave someone who has just disclosed something so terrible and so important? But how do you show your support without asking for more of that gory detail? Basically what I'm saying here on the slide is that you can validate and support without necessarily eliciting additional details. Examples of validation that can help close a conversation might include, I'm sorry this happened, or this shouldn't have happened to you, or it took a lot of courage for you to tell me about this. And as we talked about before, it's good to end by offering to connect someone to resources, whether it's peer support, like a peer support group or a mental health professional. I've listed a few examples here. Individual counseling, group therapy, support groups. Those are two different types of resources. Group therapy is led by a therapist. Peer support groups are peer-driven. And then there are sort of trauma-specific crisis lines as well for different kinds of adverse events. Okay, next slide. Okay, so this is more information about what to do in the moment when someone's disclosing a traumatic event. This is sort of on the very extreme end of what a client presentation might be. A flashback is typically associated with a diagnosis of post-traumatic stress disorder, and just because your client has been exposed to trauma does not mean that they have PTSD or that they will have flashbacks. Again, to the extreme end of a client presentation. Excuse me. Okay. But, so what do you do if your client does experience a flashback when you're with them, though? So let's start by saying that this is highly uncommon. That being said, it's worth reviewing just so you don't feel overwhelmed if it does happen with one of your clients. First, let's define what a flashback is. Flashbacks are when a person relives a past event or fragments of a past experience. And they generally occur involuntarily, meaning the person does not have to try to remember something for them to happen. And they happen abruptly. It goes without saying, I think, that they might be really intense. Flashbacks, they can look a lot of different ways, though. The person might dissociate and seem to be distant or unresponsive. They might have a panic attack. They might cry. There's no one single way that a flashback can look. Okay, next slide. So here are some tips on what to do in the moment if a client experiences a flashback. Keep talking calmly. It's okay to repeat yourself. Reassure them that they're safe. Again, I'm not training you to be their therapist, but basically how to return them to a sense of safety in the moment. Offer that person water or something to drink, or a piece of gum or candy. Chewing, drinking, or swallowing can help to ground someone in the present moment. Don't ask them about the event while they're in the middle of a flashback. As we discussed before, if they're reliving an event, their executive functioning has at least partly shut down. And so they're not going to be able to really process in any meaningful way in that moment. Your only goal then is to just try to ground them. And that might come in the form of a distraction. You can ask them questions about a completely unrelated, non-triggering topic, whether it's the weather or what they're going to do that weekend. It could be about their family or about their weekend plans. Encourage them to move or to hold something like a jacket or a towel. The tactile sensation might actually help bring them back to that present moment like I talked about. Actively use the 5 senses to reorient them. To do that, you can use questions like, what do you see? What do you hear? What do you smell? Can you feel the ground under your feet? Your goal isn't to cure them of their trauma response, but just to bring them back to safety in that moment. And of course, anyone who's experiencing flashbacks should be seeing a mental health professional. The connection to resources is key. Okay, next slide.
Okay. Thank you so much for sharing, Asher. That was a great example. Definitely, it's interesting to hear how your past experiences allow you to be more empathetic to those of your residents that you interact with. So we want to hear from you, our attendees. What kind of challenges have you faced around engaging with or supporting residents who have had trauma experiences? So earlier when we asked you about how trauma has affected the behavior of some of your residents, you mentioned isolation, anger, and other issues. So now we're wondering what kind of challenges have you faced in supporting and engaging them? It may be some of the similar issues, so it's harder to interact and build relationships because they tend to be isolated and they're less trusting. Please enter to chat the challenges you have faced. I see difficulty getting the insurance to cover therapy services. That could definitely be a challenge. Matt, this is a question I'm going to ask you, and then when we close up the chat, if you haven't answered this, I'd like for you to share. She asked, can you say some more about the pattern of clients who have experienced trauma that are not showing up for appointments due to the need for present focus and not future plans?
Sure, you want me to answer that now?
Yeah, while we wait for people to enter in the chat, why don't you go ahead, please?
Sure. Yeah, so this was a really interesting concept that Judith Herman talked about, and she was another really important trauma researcher. The idea that if you think about really traditional captivity, I know that I was more expansive and talked about sort of being captive in a marginalized neighborhood, but imagine that you are being confined or being held prisoner, and you have no idea when you're going to be, let out or released, that future thinking is really not helpful, and is in fact maybe depressing or anxiety provoking. You're really just focused on what's happening either in the present moment or in the very short future. And so what they found was that victims who had been held captive for long periods of time had a difficult time reorienting themselves to be future-oriented when they were actually released from captivity. And that concept, they're finding, actually applies in a much broader sense. So again, if we expand this to somebody who feels captive in a particular neighborhood, a community, or space because there's no opportunity for economic advancement, because of some of that institutional discrimination that we've talked about, some of the same stuff actually happens, where people have difficulty planning much further beyond what's happening today or tomorrow or a few hours from now. And what we do in the medical profession is we pathologize that, and we call them non-compliant. We say that they're just no-showing all the time, they're non-compliant, they're not interested in their care, and it can be so much more complicated than that. They may be very interested in adhering to their treatment plan, but just not psychologically able in that moment. And so that, again, informs, it sort of reorients ourselves to those clients, right? It's not that they're non-compliant, it's that they have a trauma history that we have to address.
Matt, this is Alicia. Could you, do you have any suggestions on how the staff would work with residents, or how they could help facilitate, if they can, residents overcoming this? Is it a matter of, doing things with them, of regularly checking in and encouraging them, of asking them, is your fear of not doing this that you don't think, something will come of it? Or I'm just wondering if there's any tips that the staff can use to help residents, look to the future or see to, the opportunities in the future.
Yeah, that's a great question. I think it comes down to being, first of all, really non-judgmental, right? And that's when we get back to words like non-compliance, non-adherence. Those are really judgmental words. So getting away from judgment and getting really pragmatic, really practical, and working with clients in a really practical, hands-on way, whether it's setting an alarm on a phone or helping them fill out a planner or a calendar. But coming up with really, really practical ways that they can start to be more planful. And again, the only way that you can even get to that stage is by removing the judgment around the fact that they may not be showing up to appointments or meeting their treatment goals.
Thank you, Matt.
Does that answer your question? Thanks.
Alyssa, did you have another question or follow-up?
No, although I think it would be great if once we got to the end, if we have time, if we could hear from any of the staff on the line, if they have dealt with the situation and had any successes, or also have any tips or ideas to share around the question, because I'm seeing in the chat, it sounds like trying to help people follow through is a challenge.
Yeah. Okay. Matt, we'll go on to the next slide, but I do believe we should have some time at the end so we can hear either through chat or the phone lines some more of the challenges that our residents or our participants have experienced and how they are addressing them.
Great, thank you. Okay, so now we're going to transition to a slightly different topic here. We're going to talk about how exposure to other people's trauma might affect you. Listening to trauma histories of others, it can take a real toll on all of us as providers. It can actually provoke secondary trauma in us. And that secondary trauma is sometimes called vicarious trauma. And here are two definitions of vicarious trauma that I found really useful. Lipsky describes it as the transformation that takes place within us as a result of exposure to the suffering of other living beings or the planet. We are talking about the ways in which the world looks and feels like a different place to you as a result of doing your work. And another definition that I found helpful came from Women Care Counseling. He wrote, "It is the result of hearing and seeing too much horror too frequently and for too long." Okay, next slide. So this is a quote from a mental health provider who writes about the impact of vicarious trauma on her. And she writes, "As you care for people with your heart wide open, you often don't realize how much of what you're being exposed to is being taken in and held in your body. It isn't until later that your body starts to let you know. I got home and had nightmares, headaches, and was so irritable. We need to appreciate the impact of humanitarian work, not just on the psyche, but on the entire nervous system." And no need to chime in yet, we can get to this later, but I'm wondering if this resonates with anybody. I know as a social worker, it certainly resonates with me. Okay, next slide. Okay, the vicarious trauma can really affect our work because it can lead to burnout. Burnout is defined as a state of chronic stress that leads to physical and emotional exhaustion, cynicism and detachment, and feelings of ineffectiveness and lack of accomplishment. That means that we're less able to have empathy for our patients, that we lose the ability to take joy in our work, that we no longer see value in our work, and that we feel generally depleted. And that feeling of depletion, it probably extends beyond your work, and it maybe has started to creep into other areas of your life. We might start to take that, we might start to feel that way at home too. Next slide. So here are some warning signs that you might be experiencing vicarious trauma and headed towards burnout. Feeling helpless and hopeless, a sense that you can never do enough, hypervigilance, diminished creativity, inability to embrace complexity, minimizing, chronic exhaustion or physical ailments, inability to listen or deliberate avoidance, dissociative moments, which means moments when you kind of detach yourself from the present moment, a sense of persecution, guilt, fear, anger and cynicism, the inability to empathize or numbing, or addictions. We talked before about substance use. So these symptoms look a lot like the symptoms we talked about before about firsthand trauma, right? So this vicarious trauma can actually have the same impact on us that the original trauma had on our clients. And if you find yourself experiencing any of these symptoms, then it might be time to reevaluate your self-care strategies, which is what we're going to review next. Go to the next slide. Okay, so as I've said a few times, everyone reacts to stress or trauma in different ways. Some of us are more resilient than others, but the good news is that you can actually build new resiliencies. So Bessel van der Kolk, who I referenced earlier, identified these 4 traits as essential for becoming resilient in the face of stress. And they are a sense of personal control, the pursuit of personally meaningful activities, healthy lifestyle choices, and social support. So people who were coping well with their work had those qualities in mind. And it's not that they inherently had those qualities from the start, they may have developed those traits through conscious work and self-care over time. Okay, next slide. So how do we become more resilient people? Those previous traits, they give us a clue, but here are some concrete things you can do. Practicing self-care takes all different shapes. These are just some examples. So the first one, take a break. That might mean taking a 15-minute break at work, actually taking your lunch break, which I'm sure there are many of you who are skipping it, taking a vacation, or being mindful just about disconnecting from work when you get home. Second, set goals. These might be professional goals, but more importantly, they should be personal goals. You should be working towards something that has absolutely nothing to do with your work. You can align those goals with whatever is meaningful to you. It might mean visiting every museum in town, running a 5K, setting aside 20 minutes to read every day, improving your sleep. The list is endless, but it's really important to strive for something in a concrete way, which is what we're asking our clients to do too. The third is to say no, and this is a really tough one. Sometimes our organizations might not support us in saying no. We'll talk about organizational accountability in a minute, but this might not just apply to work either. It might also apply to your personal life. Maybe if you know that work has been challenging and you need time to recharge, maybe you don't volunteer to help your friend move that weekend. Or if you know that what you really need is a night at home with Netflix and takeout, then maybe it's okay to say no to your friend's invitation to go out. We're all in the helping profession, and we're used to saying yes to other people. And so this is a skill that takes some practice. 4, create a support system. Connect with people who have nothing to do with your line of work to get a break. But also do connect with people in your field because they're going to understand what you're going through. Again, back to that peer support. But I think a balance is important. You need people that you can both talk to about work and also not talk to things outside of work. And your support network might be coworkers, family, or friends. The point is that this work is really challenging, and we shouldn't be trying to cope with the stress alone. Our plan has to involve other people. Okay, 5, connect with your emotions. One of the symptoms of vicarious trauma, and actually all trauma, is being disconnected from how we feel. And that might be intentional or it might not. So take some time to get in touch with what you actually feel. Otherwise, those feelings are going to get expressed in some kind of unintended way, like when your partner forgets to take out the trash. All of a sudden, those feelings of sadness and anger might come out in a way that are disproportionate to the offense, and your partner might take the brunt of it. But there are a lot of different ways to get in touch with your feelings, and that can include counseling, meditating, or just connecting with something bigger than ourselves by going to church, going to a nature preserve, whatever speaks to you. And the last thing here is practice mindfulness. Not only is this going to help you connect with your feelings, but it will also help ground you in the present moment. And this is the ultimate antidote to trauma, because trauma is all about being in the past. So it's about reliving the past. So for those who haven't practiced mindfulness before, it doesn't have to just be sort of traditional meditation. It's basically anything that can ground you. And again, that could be visiting a nature preserve. It could be, for some people, it's exercise. People find that very mindful and grounding. For some people, it's washing dishes. They find that sort of meditative and grounding. So it doesn't have to look one specific way. Okay, let's go to the next slide. So we've talked a lot about self-care as a personal responsibility, something that you need to do in addition to everything else you're already doing. But I also want to touch on what you can expect from your agency or organization and how they support your self-care. So as you're thinking about whether or not your organization supports your self-care, ask yourself the following questions. What are the organization's values when it comes to caring for its people? Is it a tough enough culture? Is it a do more, feel less culture? And what does the organization not want to know? what is it not able to tolerate, and how is it prepared to invest? And if you're not liking the answers to those questions, then it might be time to talk to your supervisor about ways in which they can better support you. And that might involve them encouraging you, or at least not discouraging you, from using your vacation days. It might involve them supporting individuals and taking the occasional mental health day. It might involve them setting aside time to talk about difficult cases with your colleagues, or to find a way to come together and maybe mourn the loss of a resident in a collective way. The point is that you should not be the only one who's responsible for your self-care.